Namaste and greetings from the World Health Organization. In this brief presentation, I'm going to give you a global overview of HIV prevention and care in adolescents and young people. This slide contains three definitions: a definition for the HIV, the human immunodeficiency virus, a definition for antiretroviral medicines, ARVs, and a definition for antiretroviral therapy. I'm not going to read out the definitions. They're available on the slide. I will pause for a few seconds for you to see them before I move to the next slide. In any case, the slide is available for you to look at subsequently. This slide is one of two slides which provide the rationale for investment in HIV prevention and care. It makes 2 points. Firstly, that HIV among adolescents is an important problem. In this slide, we make the case that it is especially important in sub-Saharan Africa. But this is a global problem with challenges and needs across the globe. And in the regional segment of this presentation, my colleagues will explain why it is important for the Eastern Mediterranean region. The second slide is that HIV among adolescents has major consequences, including mortality. And although HIV infections and HIV-related deaths have declined, there still are substantial numbers of young people who die every year. This is the second of two slides which provide rationale, and it makes 2 points. Firstly, that HIV prevention and management services have been shown to be effective. They can prevent HIV infection, they can prevent HIV-related morbidity and mortality. And secondly, prevention strategies and care strategies need to be planned, implemented, monitored much better than they are in order to make more progress in reducing infections and reducing mortality. The previous two slides spoke to the needs to invest in HIV prevention and care. This slide focuses on human rights obligations. It makes 3 points. States are obliged to ensure that adolescents have access to the services they need, and these services are provided with attention to privacy and non-discrimination. States must ensure that the right to health is not undermined as a result of discrimination, including because of HIV status, and states must ensure that barriers to access are removed. So there's a strong human rights obligations for countries to provide these services to adolescents and young people. This slide addresses key concepts to consider in moving forward in this area. It makes the following points. Many adolescents do not know how to prevent HIV and where to access HIV preventive services. Many adolescents, especially those in key populations, do not know their HIV status. Adolescents find it difficult to reach and obtain HIV prevention and care services. And when they can, they find that services are often not adolescent friendly. At the bottom of this slide, you find 3 specific instances which illustrate the unfriendliness of services in relation to diagnosis and post-test counseling, in relation to treatment, and in relation to disclosure. So there are issues that we can address and need to be addressed in ensuring that adolescents can obtain the preventive and curative services they need. This slide lists WHO's guidelines on HIV prevention and care with a particular reference to adolescents. Some of these guidelines are adolescent specific. The others are adolescent relevant. That means they're not addressed specifically to adolescents, but they contain recommendations that relate to adolescents as well. I'm not going to read out the list of guidelines. Suffice to say that you have access to this slide set, and if you're interested in any of these guidelines, they're available from WHO or the Geneva Foundation for Medical Education and Research. This slide contains a list of documents that are complementary to the guidelines that I presented in the previous slide. Some of them have been produced by WHO and others have been produced by UNAIDS. As I stressed, they're not guidelines, but they contain relevant information on specific issues, such as addressing HIV-affected adolescent mothers and their children. This slide simply makes the point that adolescents and young people are at high risk of acquiring HIV in humanitarian crisis situations and need to be involved in designing, implementing, and assessing services that are meant for them. This slide contains some references that might be useful in the context of HIV and AIDS in adolescents in general, but especially in the context of crisis situations. I'd like to draw attention particularly to the Interagency Working Group on Reproductive Health in Crisis manual that was updated 2 years ago. Thank you. This cartoon depicts an exchange between a health worker and an adolescent. As you can see, one of the recommendations that she makes to him is to join a support group of young people who are in a similar situation, to learn from them and get their support as he moves forward with his care.
Hello and welcome to the regional perspective for the Eastern Mediterranean region on HIV prevention and care. My name is Dr. Bridget Mugisa. I work as the technical officer with the WHO regional office based in Cairo. These are the key facts about HIV from the Eastern Mediterranean region. The EMR has the lowest HIV prevalence in the world. It's estimated to be 0.1%. And this translates to 420,000 people aged 15 to 49 years living with HIV in EMR, according to the 2019 estimates. On this slide, you'll also see the comparison with other regions on the first pie chart, which shows the contribution in terms of absolute number of persons living with HIV. And the Eastern Mediterranean region really contributes a small slice compared to the other regions globally. Despite this, when you look at the trends over time, you will note that for the Eastern Mediterranean region, we continue to have increase in new infections. That's at 47% increase annually relative to 2010. An increase in new deaths, that's 57% annual increase in deaths relative to 2010 in the region, and this is a worrying situation. Despite having the lowest HIV prevalence in the world, the Eastern Mediterranean region is one of the few regions where the HIV epidemic has not waned and continues to increase. We've seen this in the previous slide. We continue to have increase in new infections and increase in AIDS-related deaths. The region also suffers from poor access to antiretroviral treatment, with only 25% of those needing treatment having access, compared to the global level of 73% by 2020. In terms of the HIV cascades of care in the region, and when we do these cascades, we compare with the goals set by UNAIDS reaching 90 by 2020. And that is identify 90% of persons living with HIV. And out of those identified, 90% should receive treatment. And out of those on treatment, 90% should have virus suppression. So you see on this graph, the blue line represents the regional progress, And by the end of 2020, we had only identified 40% of those receiving treatment and only initiated treatment among 25% of the overall number of people who were living with HIV in the region. And approximately 21% of everybody living with HIV in the region was virally suppressed. This is a worrying situation as we're way behind the set targets which should have been achieved by 2020. In terms of the policy situation, it's good to note that 20 of the 22 member states have adopted the test and treat policy and have all the documentation related to this in place. And much as we know the absolute number of persons living with HIV in the region is low, we know that HIV infection is concentrated among key populations. They remain disproportionately affected. You see on this slide that we do have high rates of infection among persons who inject drugs. Studies done and estimates done in Pakistan show that 21% of all the people who inject drugs have HIV infection. The Islamic Republic of Iran show 93%. For Morocco, 7.9%, Afghanistan 4.4%, Tunisia 3.9%, and Egypt 2.4%. We also know that HIV prevalence among men who have sex with men is estimated at around 12.6% in data from Lebanon, 5.7% for Morocco, and 1.4% in Sudan, 1.4% also in Tunisia. The HIV prevalence among sex workers is estimated at 12.9% in Djibouti, followed by Somalia at 5.2%, Egypt 2.8%, and Pakistan 3.8%. So this really summarizes that within the specific high-risk groups, they remain disproportionately affected and continue to have high HIV infection rates in comparison with the general population in the region. Looking at the antiretroviral coverage, EMRO continued to demonstrate the lowest coverage regionally in comparison with the global progress, with only 25% of persons living with HIV receiving treatment and 23% of children living with HIV on treatment. We know also that the ART coverage varies by region. We've seen that countries that have very low burden have higher coverage rates, such as Morocco at 25%, Lebanon at 63%, Oman at 61%, and most of the other Gulf countries. Meanwhile, the high burden countries such as Pakistan, Sudan, and Iran continue to have rates in the range of 20% or less than 25%, and this is based on 2019 data. In terms of knowledge of HIV among adolescents, based on the demographic health surveys that were done in Afghanistan, Egypt, Jordan, Morocco, Pakistan, Yemen, we see that there's fairly high knowledge among the blue represents those aged 15 to 49, and then the orange represents 15 to 19. It's comparatively high knowledge of HIV. Women were asked whether or not they've heard of HIV or AIDS, and in Jordan and Morocco, above 90s, really everybody, majority of the women had heard about HIV or AIDS. Yemen, similar picture, but about 70% comparable to Egypt, and then Afghanistan and Pakistan were disproportionately low at 30% or less in terms of being able to know about HIV or AIDS. In terms of knowledge of HIV prevention methods among adolescents, again, we looked at the demographic health surveys that were conducted in Afghanistan, Egypt, Jordan, Morocco, Pakistan. And you see there's a difference compared to the previous slide in terms of knowledge of prevention methods. Jordan and Morocco showed the fairly higher rates, but still there was suboptimal, ranging between 30 to 40% of adolescent girls were able to say that they had knowledge of HIV prevention. And remember, the blue represents 15 to 19-year-olds, and the orange represents 15 to 49-year-old. Afghanistan, Egypt, Pakistan had really low rates of these groups of females knowing about HIV prevention, ranging from 5% to 20%. And this is a clear gap in terms of knowledge of prevention of HIV in the region. So during the COVID-19 pandemic, the regional office of the Eastern Mediterranean conducted the disruption of services survey. And in this, we asked countries to grade service disruption as fully disrupted, fully functional, partially disrupted. And you'll see we noted just a few key aspects of the different services to be able to estimate what's the level of disruption that has resulted from COVID-19. So you'll note on this that the red, which is fully disrupted, was mostly around prevention programming for condom distribution. Viral load testing was also disrupted as many of the machines were reprogrammed, repurposed for COVID instead of HIV. We have a bit of disruption for outreach services and outreach testing services, as well as other prevention services such as harm reduction. In terms of treatment, prevention of mother-to-child transmission, there was either partial or full functioning of these services, as well as prevention of pre-exposure prophylaxis services. So overall, there was some level of continuity with some significant disruption in prevention and testing services. Treatment services remained fairly functional, except in a few instances here and there where we had stockouts of antiretrovirals in a few countries. We further also looked at the COVID impact on HIV testing with the goal to quantify the level of reduction in testing services comparing 2019 and 2020. So from this, you'll see on the bar chart in terms of absolute number of HIV tests done. For 2019, 7.6 million compared to 2020, 2.5 million. There was a significant drop in the number of HIV tests that were being conducted. This is also reflected at country level on the same graph, and you see comparison for Palestine, Morocco, Lebanon, Iran, and Afghanistan. This slide summarizes the challenges within the region. We've seen in the previous slides that the region is left behind and has not been able to attain the 90-90-90 targets set by 2020. This can be attributed to one, limited access to services. The region, majority of the people living with HIV do not have access to HIV testing, specifically the key population groups. And as a result of this testing gap, this is cascaded into a treatment gap. Further gender-based discrimination further prevents access to services, specifically for the female gender in the region. Two, stigma related to HIV and to key populations, which further provides and presents an obstacle to uptake to services, specifically for the groups that need these services the most. Three is inadequate political commitment. We know that in the region, majority, if not all, the low-income countries are dependent on external donor funding. And this is a reflection of limited political commitment and low priority given to HIV in many of the countries. And further political developments in the past decade have not really been conducive to decriminalization and destigmatization of some of these groups in the countries. And then there is lack of integration and concerns about confidentiality. Many of the service delivery models are centralized within tertiary centers, and as such are not fully accessible to the people who need them the most. There is also reluctance to use services for fear of HIV status being exposed to communities where key populations or adolescents come from. there's poor surveillance, and one study that found that only 4 countries of the 23 member states in the region had effective HIV surveillance systems to enable them to track their epidemics. There is minimal and limited disaggregated data within the routine health management systems, and as such, with lack of this specific information, it makes it harder for evidence-based decision making to target where the need is greatest within the different countries. We'll highlight a regional initiative on this slide, which is the Egyptian Family Planning Association. This association uses an outreach model as an extension of its clinical services to engage with young people who are at most risk of HIV infection. So the strategy is to have outreach services through peer educators to extend the reach of health services, as well as to advocate so as to influence policy change to prioritize the sexual and reproductive health needs of young people within the national health system. So different services are provided. Peer educators conduct outreach sessions with young people aged less than 18 years, primarily at orphanages, at government institutions for street children. And the peer educators explain the services offered at the clinic, encourage participants to use the services, and distribute condoms as well. These sessions are offered at a location away from the clinic so that the participants' confidentiality is preserved and to avoid stigma associated with seeking HIV services. In terms of the achievements, by 2012, 81 peer-to-peer sessions were reached and almost 2,300 people, 1/3 of whom were young men who have sex with men or young people who inject drugs. Another initiative is the Test, Treat and Retain tool, which was developed by the WHO Eastern Mediterranean Regional Office. And this tool was really to assess in detail the barriers to HIV care, treatment, and testing in 2014. The purpose of the tool is to guide healthcare providers in using qualitative data to assess the determinants and the extent of engagement of people living with HIV along the continuum of care and treatment. And then also to highlight opportunities for improved access to testing, strengthen linkages to care, and improve patient retention in lifelong treatment. In terms of the achievements, we've had 6 countries in the region carry out a detailed test, treat, retain cascade analysis. And this includes Egypt, Islamic Republic of Iran, Lebanon, Morocco, Pakistan, and Sudan. In follow-up to this analysis and with support from the regional office, the countries then developed testing and treatment acceleration plans, which are now being implemented, as well as updated the treatment guidelines in line with the latest global recommendation for treatment and these were adopted at national level. In terms of the regional office, has had a regional strategy for health sector response to HIV dated 2016 to 2021 and is currently in the process of updating this strategy. The regional office, in consultation with all the key stakeholders in the region, developed this regional strategy, and this really presented an opportunity for the region to align the commitments made by the United Nations General Assembly in 2001, 2006, as well as the strategic directions for achievement of universal access to HIV prevention, treatment, and support developed by WHO and UNAIDS. So in terms of the key priorities, 1 is to maintain and improve coverage of optimized treatment among people living with HIV. 2 is to tailor programming to improve access and uptake of services for key populations. 3 is to re-engage those who've been lost to follow-up. 4 is to enhance health information systems. And lastly, continued advocacy and resource mobilization. Thank you very much for your attention. We have included a couple of references in this presentation for you to read further on any of the details provided in this presentation.